Good morning, everyone. I'll just delay the start of the meeting a few minutes if I may. I think there's a guy on car park duty there who's kind of being very efficient but slow. So there'll be people, I think, waiting, so we'll give them a few more minutes. Right, well, we will start now. So good morning, everyone. Welcome to the meeting, particularly welcome to our guests who come here to help us through the business today. We've got a lot on, so if people can keep to time, then we can keep to time overall in the meeting. So I don't have any urgent business, so straight through minutes. Can we agree those? Okay, John, update please.
Thank you. So just pulling out a few issues from my report and then obviously open to questions. So first of all, the national budget that took place, confirming the extra resources coming into the National Health Service from next year. The detail of how that resource will be deployed, utilised, will be contained in a combination of the 10-year plan and the comprehensive spending review. It is probably worth just pointing out the obvious, which the budget did not provide a long-term solution or clarity with respect to social care expenditure and budgets, and also public health, both of which are critical for our work here in Greater Manchester. We need to see the detail within the comprehensive spending review and also within the social care green paper to be able to make judgments about what our overall envelope looks like going forwards. That said, we are busy planning because we've now been put on formal notice that we, along with all the other STPs in the country, will have to produce a fresh five-year plan next summer. So all the work we've been doing collectively over the last few months on our prospectus becomes even more important. We're very close now to completing that piece of work, and I know a number of you have contributed in the last few days in terms of comments on a draft. We're now going to bring that to completion very, very quickly so that it can be submitted to government and to the national bodies in terms of our contribution with respect to where we think we want to take the work of the partnership over the period, certainly to 2021, but also looking beyond 2021 as well. In many ways, it is a preface to the fresh 5-year plan, which will draw up in the wake of the 10-year national plan next summer. At the same time, we've got the immediacy of another planning round upon us for 1920, and we've received the details of the timetable for that. This is the NHS, but clearly in Greater Manchester, we always seek to align that with the local government planning process as well. It's going to be a transitional year, 1920, because the 10-year plan will really only cut in an impact fully from 2020-21 onwards. But I think we already know from some of the signals nationally, we will see some changes in terms of national tariffs and pricing within the NHS, rebalancing particularly with respect to urgent care pricing. And we will see, I think, some movements towards the long-term plan ambitions with respect to, for example, mental health over that period as well. And of course, we're well advanced in Greater Manchester on that objective and priority. So that's looking forward. In terms of the present, there's a lot of material in my report around performance. I think the way I would describe it is that performance is tight at the present time, particularly again on the NHS side, but also the pressures that are being faced in social care. I think when we look at all of the indicators, one of the things that we see is that a lot of it is the product of increased demand on the system, and some of that is for good reasons, in terms of, for example, wanting to get more people onto cancer pathways and into screening programs so that we pick up more cancers earlier in the process. Some of it is for less good reasons, where we haven't yet got the maturity of some of our community models right, in terms of, for example, keeping people with clinical frailty safely at home and living independently successfully. There is variation across Greater Manchester in terms of the maturity of our transformation programmes, and some of that is reflected in our non-elective demand figures. We're currently just kicking off our short half-year assurance across Greater Manchester. The first of those meetings in Bury and Wigan have just taken place. It's worth saying that in each of those assurance meetings we do have some common deep dives, and the two of the areas we're looking at this quarter are our early years and our school readiness programme, and also dementia, and particularly post-diagnostic support for people with dementia. Finally, we're just kicking off some work around system efficiency and productivity, and two of the areas that we haven't really looked at very hard before at a GM level, although individual localities and trusts have done significant amounts of work, is the way that we organise our outpatients, and also the way that we organise surgery across Greater Manchester in terms of making best use of the capacity that we have within the National Health Service. So working very closely with the Provider Federation Board and others, they are two areas where we want to do some further work over the next few months to make sure that we're making best use collectively of the resources that we have available to us in those two areas of work. So I think that's all I want to say, Peter, in terms of my report, and I'm happy to take any questions.
Thank you, John. Have you got any questions or comments on Chief Officer's report? Okay, move on. Sorry.
Yeah, thanks. Morning, Chair. Morning, everybody. Apologies to coming late in the report, but I just wanted to pick up something that was in John's written report. I don't know if it was mentioned verbally, but it was just to thank John and everybody at the partnership for the work that's been done to add to the a bed every night scheme over the winter. As colleagues may know, last Thursday we moved to a position across GM where we're seeking to provide accommodation every night for every rough sleeper. It's work in progress, but we are beginning to have an impact. Not everybody will come indoors straight away, but the latest figures I have are that 92 people are using support, so they are inside, they are being supported, and already, in one case in Trafford, somebody's been rehoused. So the scheme is building. I would like to thank the partnership for providing, I think, flu jabs as part of the scheme. Also, I think mental health outreach, that will be crucial, I think, Peter, if we're to ensure that people get the help they need once they're in a stable position. It was just an opportunity to thank everybody involved for the work that they've done. It is groundbreaking. We are the only city region in the country that is doing this, but I think it's the right thing to do. One night out on the street damages not just people's physical health, but their mental health too. We think this partnership could set a new standard for how we deal with rough sleeping. So it was just to thank everybody, but to repeat the need that we will need as much possible, particularly mental health support over the coming winter if we're to make a success of the scheme. But it was a huge thanks to everybody who's been involved, particularly Helen, working at the GMCA on this issue.
Those comments. Anything else? If not, we'll move on to item 5, safety report. Richard?
Thank you, Chair. I'm very pleased today to bring this paper which describes safety of care in Greater Manchester. To an extent, this is something of a stocktake paper, and that it's intending to draw together quite a lot of threads of work that have been underway for at least the last 3 years, but also very specifically to start to describe some of the direction for the future. Our patients, our service users, ourselves have an expectation of safety in care, and it's important that we should fulfil that expectation. There is no single national approach to safe care, and to an extent, safe care on a national agenda is dominated by measures of harm as opposed to measures of excellence. So this approach that I've described is starting to lay out a direction for Greater Manchester which is very firmly based on an excellence approach. Those ingredients of good care that lead to safe outcomes for our patients and service users. So it builds on the work that we did on the Quality Improvement Framework last year, and it starts to draw on some of the principles in that. Today, I'm asking the board to support us in making this a top priority, and we will undertake to give a clear and current picture of safety going forward at the Greater Manchester level. Already that's something that happens within teams, within providers, within organisations, but we'll try to draw together an overview picture across the whole of health and care, which allows this board to have clear sight of safety in our system. It will be an approach which is based on a supportive learning culture across Greater Manchester, and in doing so, this will be the first ever approach of this kind. It seems illogical that that's the case, but there has not been a national or regional picture that's been done in this way, and if we support this today, this will be a first again for Greater Manchester. So my ask of the board today is to support the approach that we've been taking, to provide us with your support for the continued development of this approach to safety through the Quality Board in consultation with stakeholder groups, and ultimately to note that this is the first of its kind, and we should be proud that we're taking this first step together. Thank you.
Thank you, Richard, for that. Again, any questions or comments on Richard's paper? Tom?
Okay, thank you, Richard. So, in your paper, you make mention of the first GM Clinical Leads Summit, which took place last Friday. So, I just want to briefly touch on what an excellent event it was. Over 150 clinical leaders in the room across GM for the first time. And there was a real focus on safety with a couple of inspirational talks that we received from a patient and from a National Clinical Director for Safety. And it really shed place things in a new light. So, you know, making us think about a no-blame culture, looking at celebrating good practice when things go right and learning from each other. And also supporting the workforce's well-being when significant events are investigated, because that can take its toll on us as clinicians. But in terms of this paper, I think it's great to see a real emphasis on safety across the system and not just across organisations, and also focus on medicines and handover of care, which we know are high-risk areas. In terms of things just to sort of emphasise and want to bring to people's attention, I think it's important that we adapt the Vincent framework for use in non-hospital settings, and that we have whole system health and social care engagement in this. I think that's pivotally important. And also that we can develop safety metrics which reliably measure improvements in non-hospital settings, as a lot of the data collected is in the hospital settings, but, you know, fully supportive of this as a clinical commissioner.
For raising the clinical summit, it was the first event of its kind, bringing together leaders from across the system who are leading work across the system. So breaking away from the organisational hierarchies and trying to look at people who are working across sectors, across localities. And thank you for the feedback. Just to illustrate how successful that was, we had tables of people from different parts of the system working together. I don't think we've had examples before where we've got 4 hospital-based consultants sharing a table with 3 registered managers from our teaching care homes programme, talking about how we can work together as a whole system to improve the care and the experience for our patients and service users. So it was the first, it won't be the last, and not surprisingly, it was a key area of focus for safety. We will bring some of the output from that event first to the Executive Board in due course, and when appropriate, we'll come back to Health and Care Board with the requests from that group of Health and Care Board, and indeed the offers of support, and that's where we're heading with that piece of work. Thank you.
One of the things I just want to stress in terms of what Richard's report and what he said is this is about health and social care. So this is about safety across our provision, and again, that's obviously partly what makes us unique as a partnership. And just to report some encouraging news, but news we can't be complacent about by any means, which is we just got our latest figures in terms of the care home CQC ratings, and we've halved in the last 12 months the number of care homes in GM that are rated inadequate. So we've got 12 left out of 560. Now, we don't want any, so we've got to deal with those 12. It's not acceptable that any care home is rated as inadequate, but it is progress. In fact, overall now we have 72% of our care homes in GM that are either good or outstanding, up from 55% when we started. So that's a 17 percentage point improvement. But clearly, again, 72% isn't good enough. We need to, ultimately have 100% of our homes that are good or outstanding.
Anyone else? Well, thanks for the comments on that. And again, something we're doing different here in GM because of the devolution. So Richard went through the recommendations. We're happy to endorse those. Thank you very much. I'll move on to, again, something else that we're doing very differently, I think, in GM than in other places. So, report on mental and emotional wellbeing and education settings programme. So, for you doing this, thank you.
Okay, thank you. Good morning, everyone, and thank you very much for inviting us here this morning. For those of you who don't know me, I'm Sandeep Renaud, and I'm a consultant child and adolescent psychiatrist and also the Children's Mental Health Lead for Greater Manchester, here with a team that will introduce themselves. But just to set the scene, we're here in a week that some of us celebrated Diwali, and it made me think about what a rich and diverse community we have across Greater Manchester, and that's what makes it so great. We have many differences, but actually one of the things that we all have in common is our health, and the foundation for that health, which is our greatest wealth, is absolutely our mental health and emotional well-being, no matter what age you are. But actually, the importance is, you know the figures, 3 in every classroom of 30 has a diagnosable mental health condition in our young people. And only a quarter of those young people are getting access to the right care, and that's not acceptable. That's why it's so crucial that we start to look at education and prevention in the early years, and that's so vital. Last year, or just over a year ago, you would have heard that in Greater Manchester there was a £134 million mental health transformation investment proposal, and 60% of that is to support children and young people. That's unprecedented. It's the first time that's happened. I've heard lots of firsts this morning, and again, that's another first. Very welcome by us working with children and young people. So with that, we're doing lots of transformation priority works that include a complete redesign of crisis care that you will have heard about, workforce training, transitions, parent-infant mental health. But what we would like to share today is a little bit more detail about that work that we are doing in education settings and across the whole of our education settings with young people. Why? Because we've got to get that early intervention right, and we absolutely have to create that community where our young people don't just survive, they are actually going to thrive. So, without further ado, I'm going to hand over to different members of our team to share our story. Thank you.
Good morning. My name's Lisa Fathers. I'm Director of Teaching School at Altrincham Grammar School for Girls in Trafford, and I'm also part of the Bright Futures Educational Trust. I have another hat as well, which is that I'm a national trainer with Mental Health First Aid England. I've been a teacher for 22 years, and for me, this is the most exciting project that I've ever been involved in because it's cross-sector. We've learnt a lot in terms of schools working with the NHS, and other organisations, and actually, you know, our children are in schools 5 days a week, well, most of them are, every week. So what a great place to be able to work with them and do some of this preventative work. And what we want to do is move rather from treatment to prevention. So I'm just going to talk you through what the actual project looked like. So it was a rapid pilot. We had to work at speed to identify a number of schools who could come on board with us. The partners involved were my teaching school, the Alliance for Learning. If you don't know what a teaching school is, very briefly, there are schools dotted about that have been identified as having the capacity to work with lots of other schools and improve them. It's a bit more complicated than that, but just for your understanding. So we had a teaching school, the Youth Sport Trust, which is a national charity, and really making that connection between mental health and physical health, which we feel is absolutely crucial. Place to Be, who I'm sure you're familiar with, and 42nd Street, and of course the MFT CAMS, who provided a digital clinic and a real opportunity for information and guidance. So what we did was we worked together and put a complete package around 31 schools, and this involved Year 5 students and Year 10 students doing resilience workshops with real athlete mentors. So these are sports people who were taking their learning from kind of being on the pitch or being in a race, and helping our students think about how to get ready for exams, how to manage stress. My teaching school provided mental health first aid training to middle leaders and senior leaders. Place to Be worked with senior leaders across the schools to really think about a whole school approach to mental health and well-being, and 42nd Street provided additional workshops, and it was really, really exciting. And I'm going to hand over in a minute to the students who will talk a little bit more about the impact. But one point that I wanted to make, just for your understanding, was that schools sometimes are funny places to infiltrate, and what we like as teachers is to work with other schools, and we like working with other educationalists because we feel that that's credible. So the fact that the teaching school was at the heart of this, in terms of coordination, those relationships with schools, being able to understand how schools work in a rhythmical way, and the timings of the school day, and all those things that, unless you've worked in a school, you might not get. And that's no disrespect to you, who I'm sure might be parents with children in schools, etc. But for me, that was a crucial part of the success of the pilot and the way that we were able to operate at speed and get the pilot off the ground in 2 weeks' time, because we heard 1 week we needed to do this. John wanted it to start kind of tomorrow, and within 2 weeks, within 2 weeks we were up and running when we were in all the schools with a complete package. So I think that's testament to the way that we've worked in a cross-sector way. So I'm going to hand you over now to Mia and Sam.
Good morning, everyone. My name is Sam Bamideli, and beside me is Mia Biedov, and we're from Cedar Mount. We've been appointed to be student ambassadors for mental health, and the entire program, the Rapid Pilot, was done for us at Cedar Mount.
So, as Sam said, we started our journey by being identified as potential mental health champions by our progress leader, and started working aside Ms. Carson in identifying group of students with mental health needs in our year group. So we had 2 visits from an athlete mentor, Neil Dance, from Youth Sports Trust, and we received a practical training on importance of mental health, which taught us that mental health isn't only something mentally, but it also depends on your diet and your amount of exercise you do and your lifestyle. And the session was supported by James, a representative from 42nd Street, who also did activities to help us identify what good mental health looks like in our school and what we would like to see in the future.
Prior to the pilot and the entire program, all of our staff have received mental health training. So they've met with identified students, either alone or as a group, to get familiar with them. They did questionnaires, numerous activities, just to enable them to know that there is support and who to approach. Through the pilot program, a number of staff have received the first aid mental training. So we feel this is important in developing the need for support and to develop the interest in the importance of mental health. We now have more staff who aim to take the training to a higher level, whether it's adult mental health or even counseling training. We have future plans to deliver assemblies and meetings to students and further training sessions for more staff. Our previous staff who've been through the pilot and the entire mental health training want to support and encourage other staff as they value the training they received.
So our mission includes leaving the legacy and for future generations. As we're in year 11, we already know the pressures of mocks and exam stress, and we want to make sure that these aren't the pressures students are going to battle afterwards. Which makes us really keen to train mental health champions in all year groups and raise awareness of issues young people face. If we build a culture of acceptance and awareness, we will help our peers in developing positive mental health and resilience. And lastly, I just want to say thank you for everyone that has made this pilot a thing and made it happen, as it is such an important topic to discuss. And it is an amazing opportunity for us being a part of it. Thank you very much.
Thank you. So just in terms of the impact, we have got some impact documents that we will leave with you today, but essentially the feedback has been overwhelmingly positive. We have trained over 800 members of staff in mental health first aid. We have teachers saying that they feel much more confident now. We have our primary school students and secondary school students saying that they feel more supported by their staff, but they also feel like they are aware themselves of how to look after themselves better and how to look after others. And then kind of some of the more fluffy impact that our teachers and schools are telling us is stuff around the fact that actually this pilot has changed the culture and the ethos in the schools, because something that was quite taboo is now very explicit. It's on the walls, it's in assemblies, it's in schemes of work, and actually the impact of this is still being seen because some of the work is being sustained by the students and the staff themselves, who've been so inspired by the project and by being in the pilot that they've continued on with their learning and they're continuing to do work on a weekly basis. So only yesterday I was in a school that was having a mental health awareness week because it was stress awareness day on Wednesday, and they were talking to year 3 and 4 students about what their stresses and anxieties were and what were in their stress buckets, and they've got language to do that now. I think the other thing that I just wanted to leave you on was just one practical example from one primary school in Gorton, and this is from Stanley Grove Primary School, where they have actually changed their first aid stations in their schools that are dotted around to be physical first aid stations and mental health first aid stations. And one little girl called Natalie said to me, "Miss, I know that I can go to a place to talk about the things that I'm worried about just in the same way that I would do if I had a cut finger." And, you know, if we want impact, then that really is impact. We're really excited that we're going to be continuing with the rapid pilot into phase 2. And I'm now going to hand you over to Polly, who is the Director of Student Services at Salford University, and she's going to talk you through the university element of the work we've been doing. Thank you.
Thank you very much. Good morning, everyone. Thank you for having us. I thought it might be useful just to give a few examples of why we think that students have particular requirements and also are a group worthy of particular attention. The cases that I'm going to talk about are fictional, but they're based on real cases. So if I talk about, for example, Joe, who was on the waiting list for treatment for borderline personality disorder for 12 months, just as he was offered treatment, he had to leave the university and return to his family home in Kent, where he had to start the waiting list all over again. So students move around a lot, and that's just one example. Obviously they can move across all sorts of boundaries, and it can be quite difficult for them to either bring their care with them when they come to university or maintain it while they're at university. So then, talking about Lydia, she had to interrupt her studies due to mental health issues and couldn't complete the year that she was studying in. As a student, Lydia is not eligible to claim benefits even if she can't study, but also she can't receive her student loan for the next year, her maintenance, if she's not currently studying. So as she was too ill to work, Lydia had to withdraw from university. Students only get 4 years of funding in total, although there is an appeals process. That's obviously putting another barrier in the way of someone that's already got mental health issues for them to access university. And returning after an absence, again, is not always easy. Sometimes courses have changed, they've moved on. It's not as straightforward as just take some time out and come back, although we try to facilitate that as much as we can. So they have that short window of opportunity for us to really enable them to make the most of it. So then we do have services in the university, but we're not really making the most of the opportunity to join up with the NHS services as well. So if I think about Taz, who attempted suicide, her flatmates found her. She lived in a flat with 6 students, found her and got her to hospital. She was discharged back to her flat in the small hours of the morning. Obviously, because of information sharing, there was no notification to the accommodation provider or the university. So her flatmates woke up when she came back into the flat. One of them didn't sleep for the rest of the night for fear that Taz was going to make another attempt. One of them actually left in the middle of the night to sleep on a friend's sofa because she was too stressed to deal with the situation. Another flatmate had mental health issues of her own and started having panic attacks and suicidal thoughts. So again, there's an opportunity there. We could have managed that much better between us, but we don't always do that. And there's also a great opportunity here, not just to work better together, but also because this is genuinely a young population and a group of people who, even if they're not younger, have taken the time to look for a change in their lives. So they're potentially at a crossroads. So Kayla attempted suicide in the first few weeks of term. It turned out that she developed a lot of secret coping mechanisms when she was at home, and that had all completely fallen apart when she came to university. So she was quite quickly diagnosed with autism, and after accessing support for that and having help and support to develop new coping mechanisms, she's doing brilliantly in her studies, and she's got just absolutely a new lease on life. So I think I probably better move on from there, but hopefully I've given you a flavour of the issues that we were facing. So having the opportunity to get together with colleagues in other universities, the 4 Greater Manchester universities, and now the Royal Northern College of Music has joined us as well, and also to work with colleagues in the NHS, the fact that something is actually coming out of this, something concrete, is honestly amazing. I can't tell you sort of how satisfying that is. And so what we will be doing is in a genuine partnership where we all contribute financial resources. We will all be contributing services that we bring, that we're already doing, and our best practice that we can already put on the table. We will also be jointly managing the project. So I think we can call it really the most genuine kind of collaboration. In fact, we've actually just jointly also applied, we've made a bid to the Office for Students for additional funding for a complementary project, which I think shows even though we haven't got this piece of work up and running, we're already very much working as a team. I don't know if is there another slide there that's just to talk about the features. So it is about very much building on the provision we already have, bringing in new provision where that's needed, the joint working so that we can make the most of what we've got and have more than the sum of our parts. And I think also ensuring that we're working very much in the same way so that it's seamless and it's as smooth as we can be. Are going to be features of this piece of work. So again, I'd just say thank you because we really appreciate this opportunity. I think it's going to be fantastic for the students. I wouldn't necessarily myself claim to say it's a first, but certainly I'm not aware of anything like this in terms of talking to my colleagues across the university sector. So, thank you very much.
Thank you, Polly. Thank you, Mia and Sam. Thank you, Lisa. I am going to say one thing, Mia, I hope that's okay. Mia wants to be a surgeon. I'm heavily persuading her to reconsider and join us and join me in psychiatry. I think I'm getting there. I'm getting there. Anyway, that was just chapter 1 of our story. And I hope that it's given you some food for thought, perhaps some questions, and that you will all take away something positive. But like I say, it's just the first chapter. Manchester has been known for so many firsts, so why should we stop now? This again is 2 firsts rolled into one. It's a first. It absolutely is. And we're very proud of that, but we now need to deliver, and there's a lot of work to be done. We know that that's a challenge. The next phase, we are in discussions with our national bodies around funding, resourcing, to move us to that phase 2 and beyond. And also in terms of the university work, we're kind of doing the same and we're getting there, and that vision is there. Certainly the collaborative working and cross-system working is absolutely the key to how we will succeed. And what I want to just kind of end with really is that what I hope this demonstrates is true parity finally that we're trying to get to for physical and mental health. I want to still be alive when we start talking about just health and well-being and stop separating the two. So that's one thing. And what we're trying to do is create everything from the calm classroom to the calm campus. That is very much what we're trying to do here. We know that educating young people and providing them with tools is absolutely going to be the most powerful tool to make that change. And I'll leave you with the words of Lincoln, which is that, you know, the philosophy and the culture, which I've heard a lot this morning, that we can create in our classrooms today can very much become the philosophy of the government tomorrow. So thank you very much for inviting us. Oh, there you go.
So inspirational.
Okay, let's get up and dance, Warren.
Yeah. Well, thank you very much again for the presentation, wonderful presentation, and I think Sandy summed it up. It's working together, it's going to change this. It's not just a medical intervention, it's everyone, so we're here to help, and as you say, there's a lot of work still to do. This is the outline of the programme, but we're here to help to make sure that it does work, and it does work for our young people. So thank you very much. Andrea?
thank you, Chair. I'd love to see this approach across all of GM because I really think that it's something that we need in our communities. Young people with mental health issues really struggle to engage with education, and it's better for everybody if we can prevent that or, you know, build that resilience within our young people so that they can, be educated and want to engage in it. I think particular emphasis also needs to be given on the transition stages within a young person's life. Young people suffer from loneliness, and we need to acknowledge that and put services in place to deal with some of that, and perhaps a community approach to dealing with loneliness, all age loneliness. I think one of the saddest things that I heard a young person say to me was they're just getting through every day. It's a struggle to get through every day, and that's really sad for somebody young to feel like that. But I think the pressures on our young people are so immense. There are pressures with social media, there are pressures with all sorts of things, exams that they have to deal with, and we need to build that resilience and really sort of put the emphasis in our young people. I think that's about it, but I really welcome this, and I think if we could roll it out across GM, it'd be fantastic. Thank you.
Thank you very much. Great work. It was only 2 days ago when we in Oldham Council, full council, heard from care leavers how they struggle with their issues despite being in employment, which is usually quite low-paid jobs, apprenticeship. We heard the stories where they had to choose between buying food or paying for their prescription for antidepressant. I know they've spoken to Mayor as well, and we are very keen to support them whichever way we can. It's a great project, and it will be great if we can roll it out across Greater Manchester. But what we'll be really very keen to see, how do we link our existing resources with this project? So this project is not working in isolation. So like when we commission our school nurses, when we commission our health visitors, we commission various other health professionals and social care workers, and we have sort of like focus care workers. They all are doing great work in isolation. How do we bring all of them together? So actually a young person gets one offer, and it's not up to the young person to keep knocking on different doors. It's up to us as professionals to actually navigate them and transfer them from one service to another service. So we have what we call safe clinical handshake. One of the problem mental health sufferers will tell you they suffer from, it takes a longer time and courage to come forward and actually admit that you got a problem. And what we do as professionals, when they admit, we just send them from left to right and right to left, rather than just trying to actually take the responsibility. So I hope this project will link with everything else that's happening around GM and address the issues. Thank you.
So thank you for the presentation. I thought it was excellent, and look forward to seeing it being rolled out in Wigan. And it's just to pick up on the previous point that was made. In Wigan, Wigan Council for care leavers, they've offered the staff support that they give for mental health to all care leavers, which I think is something that could be done across Greater Manchester as the corporate parent, but also should link into something like this.
I just want to congratulate everybody involved with this project, Sandeep, Lisa, Polly, Sam and Mia, everybody involved. It really is as exciting as you all said. I can't believe that John just came up with an idea and said you've got a week to go. I would never do something like that. I can't imagine that. But thank God you did, because really, I think this is the most exciting thing actually that the partnership has brought forward, certainly in my time since being elected, because children and young people's mental health is a major issue of our times because of the nature of the way life has changed. I see it and feel it with my own kids, and I bet other people in the room do with theirs too. And yet, services have just not caught up with that at all. So mental health, as we all know, has been the poor relation of the NHS, but within the mental health budget, I think I'm right in saying that child and adolescent mental health gets less than 10% of the spending. Now, how can that possibly be right? It can't. And it means that we can't have the preventative approach here in Greater Manchester that we talk about so much. I've been to Stanley Grove the day when Lisa was there too. Just seeing that station, I mean, that's no money at all. That's not even resources. You know, that is just real societal change on the ground that I think will have lifetime benefits for the young people who are taught to understand what that means, and they deserve real congratulations for doing that. Peter, if I may, 4 very quick points. The first, Lisa mentioned physical activity. I do think this project needs to link to what we're doing around physical activity in schools. For me, being physically active is the first step in good mental health. So linking it with the Daily Mile, I think, is important, and the other work we're doing in secondary schools. Secondly, I think it's also important, particularly in the context of secondary schools, to link it to our work around curriculum for life. Young people need more support when it comes to financial literacy, online literacy, health advice broadly, a whole range of information that they are not getting through the ordinary curriculum. So we are working with the Curriculum for Life with the Youth Combined Authority, but I do believe the mentally healthy schools concept needs to knit together to that, because both two sides of the same coin. The third point I would make, Peter, is I don't think this partnership can see this as a project that sits on the fringe, and I think Zahid was making this point, and Andrea too. It needs to go mainstream, in my view, quite quickly. Now, I know there's an issue with resources, but some of this isn't necessarily expensive. I just think this has to become part of what we do, given the level of need that is unmet, that is out there in our schools. And I'd just be interested to see how do we embed this very quickly, because it should just be part of what we do working with our schools. Lastly, you'll be pleased to hear, I think there are national policy issues here, not just for the health service, but for the Department for Education too. And I would be interested to know whether or not the schools involved could really begin to feed back information, particularly on the education side, what is happening with the curriculum and testing that is meaning that pressure and stress is being transmitted to young people in a level that I don't think it was even a few years ago. You know, what is changing? Because it is the case, I think, that young people are receiving that message from schools, and they are becoming more stressed, I think, than they need to be. So should Greater Manchester make a statement about that to get things back in better balance? Because I don't think the direction of travel at the moment is right. Thank you.
So there were lots of very, very good points, and between Lisa and I, probably we will, I think, offer some commentary back. What I did want to say, sorry, I've forgotten Zahid, some of what you were saying around apprenticeships, but also, very importantly, further education colleges. So by no stretch of the imagination, it was rapid. So there's, obviously our commitment, we couldn't do everything all at once. We had to kind of concentrate and test one thing. We haven't forgotten that there are also lots of young people not in traditional education settings, number one. We also have looked after children care leavers. We have those that go on to further education colleges and apprenticeships. So, and they are different cohorts and they do have different needs. So again, it's a phased approach and it's iteratively developing, and we have got plans for that. So that was one point I wanted to make. The other point about cross-sector and systems, and absolutely we should have a one-stop shop approach rather than, it's hard as a professional sometimes to navigate. And I'm also a parent, so when you flip it around the other side, it's really frustrating when you're a parent who has children, who has a career, who has lots of other things going on, and when you see that complex system. So I think what devolution offers us, and I see this for the first time in my frontline clinician career of 22 years, I have never worked in the way that we're working now as a system ever before from the localities. So from, for instance, Wigan and across all our GM localities, we are actually seeing much more system working. So that one-stop shop approach for children. So most localities are starting to develop children's hubs, which is absolutely to knit together rather than duplicate and bring people together. So again, it's a challenge, but we will get there. You also mentioned that, you know, school nurses, health visitors, all of that system. One of the things that we are now in discussions with our national bodies is the development after the Green Paper of dedicated mental health support teams to schools. So that's about bringing the system together rather than that complicated lots of interfaces that has not been helpful to anybody. But we are going to do it differently to nationally. The way that we're going to do it differently is we very much believe that those mental health support teams to schools are not just NHS, that they are actually representative of the whole system. So our voluntary and community sector colleagues, our social care colleagues, you know, youth support workers, people that actually young people you know, engage with much better. So it goes back to your community point. And we absolutely don't just want young people to feel they're getting through each day. That's my point about we want to create communities where young people start to thrive, not just survive. So that picks up some of those things, I hope. And the other point, Andy, I think around physical activity, which Lisa will comment on, is in the pilot, that was the part of the kind of prevention social prescription that we wanted to include, but by no means is it the end. So that slide you saw of the health state, the physical and mental health first aid station, our vision, or at least my vision, is wouldn't it be great if we had alongside the monitors for first aid, we had our social prescribing monitors in schools. By that, you know, we need to bring back the creative arts, music, performance arts, drama as a means of building that resilience. And actually, what I hadn't appreciated, Lisa, before we did a lot of this work, is how much of that has gone from our curriculums across particularly secondary schools, and that's not acceptable.
So just to pick up on that, so a couple of things. First of all, totally agree about the Daily Mile. Obviously, I'm sure you're all aware we're one of the first city regions for that. And actually, it's not explicit in the pilot, but what we have done is made sure that those schools that we've worked with have engaged with the Daily Mile and signed up to that. So for those of you that don't know, it's simple as it sounds. Children go out once a day and complete a mile with their teachers. The impact of that has been that the teachers, the senior staff and the students are getting fitter and healthier, and we know that active schools are healthier schools. The other thing that I'm doing kind of alongside the pilot is joining up the Daily Mile with the Manchester Marathon, the Youth Sport Trust, so that we can make sure that we're really having an impact and we're getting that message to schools. And that was the work of the athlete mentors explicitly through the pilot. I think the other thing that I want to say is, yes, please, do help us shout about the impact of higher accountability levels, changing in Ofsted framework, the fact that we've got to fill various buckets for the EBAC, because it's that has meant that we have had to narrow the curriculum in some schools, because we have to make sure that we meet those outcomes that we're being measured on. And actually the impact on teachers' health and well-being is huge. And if our teachers and our leaders in schools are stressed, then actually that doesn't make for a very positive ethos for the students. So it's a complete circle and it's a big knock-on effect really. And we know that we're losing teachers in droves, so recruitment and retention is a massive issue in education. So actually, if you can help us feed back to DFE, regional schools commissioners, anybody that will listen, that actually we need to balance and make sure that our children and our staff are healthy in schools as well as achieving their full potential academically, that would be really helpful. Okay.
Okay, well, thanks for those comments. I think one of the challenges that Annie's given us as mayor is to actually try and make sure that young people achieve the potential. Obviously, partly there's a focus on school readiness, but clearly if we don't get people's mental health right, if we don't give them the support, then of course they don't achieve the potential either. So it's really important for us as a city region to get the young people together. So Hopefully we are doing it different. Thank you very much for your work that you do. And as I said earlier, we're here to support, to make sure this is a successful project. It is so crucial. So thanks again for coming. And if you want to sneak away now rather than listen to the rest of us, you're welcome to. Well, one last thing, Mayor, on the radio today, I heard our surgeons just becoming robots. So really, I think Sandeep is right. I think Dharmesh taking the next one.
Thank you, Chair. So I'm really glad to be able to share this paper with the board today as an update on the local professional networks for dentistry, eye health and pharmacy. I'd just like to take a moment to introduce the chairs. Moshan is chair of the local dental network and a dental practitioner in Oldham. Jane Brown is chair of the pharmacy network, and myself as chair of the eye health network. And I'm going to share this paper on behalf of all of us. I think the paper is there for all to see, and what hopefully you'll see is that the networks have been contributing to the strategic priorities in Greater Manchester, with particular focusing on developments which are improving the care and experience for particular patient groups. What I'd like to do is take the opportunity to highlight certain key programmes of work that we would like to share with the board today. As you'll see, through the Healthy Living frameworks, wider primary care has been supporting and empowering patients in self-care, in particular looking to making prevention a key priority to support the improved outcomes that we've all been collectively looking to achieve. Key highlights being that 90% of all our pharmacies now are accredited as Healthy Living pharmacies, with particular focuses on oral health, bowel screening, physical activity, in particular linking to the GM Moving programme and supporting the GM Tobacco strategy. And actually what we've seen is, following the great success of Healthy Living Pharmacy, is the development of this in dentistry, with the development of the Healthy Dental framework, and now also for optical practices, to really trying to capitalise upon those interactions with patients who may or may not actually interact with other healthcare professionals in the normal way, whether that be the GP or any other opportune moment, to hopefully support making interventions at an earliest possible stage. Also, what's been really critical in some of the work of the LPNs has been a collaborative approach, which we've heard a lot about today in this sort of system-wide working, and that's been no less in the LPNs, the professional networks working together, largely noted through the close working of the dental and the pharmacy network around oral health programmes and the raising awareness of oral health through pharmacy, and building local strategic neighbourhood working between pharmacies and dental practices. And going further, the last year has seen the launch of the See More, Learn More, Go Further programme, which has been about how we support encouraging children to attend for sight tests in Greater Manchester. Through a GM Eye Health Needs Assessment, we were able to identify that only 1 in 5 children attend sight tests each year. And this fundamentally impacts on their ability in terms of development and attainment in school. And this programme has been rolled out working with schools and parents and children in Stockport and now beyond. And we look forward to sharing a short video about this project towards the end of this paper. The LPNs have done a lot of focus work around how can we support community-based services, and the Eye Health Network has been working closely with optometry colleagues in developing a primary eye care service framework, which looks to recognise the greater role optical practices and their teams can play in the delivery of eye care and wider general health from optical practices close to people's homes, near where they work or where they care for their patient, family members. And this will fundamentally help some of our most challenged acute services. And similar programmes have been discussed and worked through our pharmacy network, in particular looking at what's been mentioned by Richard earlier, the focus on patient safety and how we ensure seamless transfer of care from one part of the system to the other. And Healthwatch has been working closely with Healthwatch and engaging with patients to understand how important this is and how we do this, and the expectations that the population and patients have of us as a system. The local professional networks have a broad reach, and that covers prevention and primary care through to secondary care and the third sector. And lots of work has happened, in particular in the dental and the eye health workspace around this, with substantial demands on our secondary care sector in both these areas, ophthalmology being the second highest outpatient attendance at hospitals in Greater Manchester. And our hospital colleagues have been working closely with the networks to engage in national and local programmes to really help and look at how we manage that demand and capacity better. As I said earlier, a lot of focus has happened through the professional networks on how we work and support particular patient groups. In particular, the homeless, patients with learning disabilities, patients with visual impairment, and patients with dementia. I just want to highlight one or two small points in these areas, very much in line with what's been discussed already so much today. Following the challenges around homelessness, which the GM Homelessness and Health Plan has laid out, and the Mayor has, all of the dental networks, all the local professional networks have been looking at how we can use our contractors and practitioners out there to support the homeless population. And in particular in dental, there's been the setup of a pop-up service delivered in mobile units which travels to many different centres, working with community groups and charities. And that's in addition to working alongside the GM Homeless Medical Service. So this is, quite an achievement in terms of dental service for homeless patients. And actually similar developments have actually been developed around the provision of sight tests for patients who are homeless to enable them to see well and try to get back into employment, etc., which we're hopefully looking to roll out in the coming year. Sight loss, visual impairment is something quite often that we forget about, and this patients are not an insubstantial number. We look at the patients who have sight loss in Greater Manchester, they're equal to the number of new births we have in Greater Manchester in any one given year. And sight loss affects every aspect of someone's life, from the ability to make a cup of tea or to recognise a face. And actually when we have discussed this with patients, what they tell us is actually they feel isolated, they don't know where to access services and access support. And so we've been working very closely with the third sector and the Greater Manchester Visual Impairment Forum to develop a comprehensive community sight loss framework, which we hope will be led and delivered by the third sector, and this has been analysed as an option for delivery over the coming year, and hopefully this will help us keep patients independent and thriving members of their local communities. Additionally, dementia, we say actually with dementia the number of interactions we make is absolutely critical, and we have a huge opportunity amongst the large number of interactions that optometry, pharmacy and dentistry make to really capitalise upon this. And there's been great work done in pharmacy around the dementia friendly framework, and we have over 2,500 dementia friends now across our community pharmacy teams. And dentistry has done a lot of work around how we can support patients with dementia who are trying to access dental services and to encourage them to access dental services through a toolkit and substantial work with the dental workforce. So hopefully I've rattled through what is a very broad range of work that's ongoing at the moment, and you'll see that there's a lot of work ongoing, and there's a real ambition and vision across the other networks and the teams that support them to really strive and develop these further, and hopefully with the support of this board, the partnership and all the system organisations, we can really further progress on these. What I'd like to do is just share a short video regarding the Seymour Learn More Go Further project, as you'd expect from myself as an optometrist to do, about this particular project and what it's achieving.
I brought her daughter in for an eye test because she has said that she couldn't always see writing on the whiteboard at school. I also noticed one day she couldn't see a bus number.
It is really important children have their eyes tested into that probably once a year. The NHS funds sight tests for children under the age of 16 and for those that stay in full-time education up until 18. The NHS also help with the contribution towards the cost of glasses should they be needed, so that will mean a lot of optical classes will provide glasses free of charge.
I'm glad I have my eyes tested because it means I can see the book at school. The optician was very helpful when I had my test and made it very simple to understand.
We use our sight for everything. And actually children change, children grow, their eyes will change throughout their lifetime as well. They will not necessarily report to their parent that they're having a problem. The children will get used to things being blurred and that will be normal, and they don't know necessarily that it could be better than that.
Even if you don't think you need it, it might be thing you didn't know is to do with your eye health as well as just generally being able to see.
It's really easy to do, it's easy to put, they just do it.
Thank you, Chair.
Thank you. Do you colleagues want to say anything from the other networks? Would you want to make a contribution from the other two chairs of the network? So?
I don't think it wants me to say it. I'll try from there. Is that everyone can hear that? Yeah, I think what I'd like to do is wholly support what Dharmesh has managed to rattle through as quickly as possible. You know, when I personally, when you think of dentistry as a discipline, and I go and meet some of the other LDN chairs around the country, one thing that they don't have is what we have in Manchester, where we've got some cross professional work in. We're trying to break through and hurdle these barriers that have been there over the last sort of 20 to 30 years. And some of these programs, especially Healthy Living, has given us an opportunity to try and link, especially in neighbourhoods, pharmacies and dental practices together. And we'd hope to be able to do the same with optical practices as well. But what we do need is, the support from the partnership to make sure and keep us enthused to be able to do that as well, and try to help us through any other sort of organisational barriers that we have, because we've managed to get through our discipline barriers, but we've also got certain barriers in other wider primary care services as well. We'd appreciate the support from the partnership for that as well.
And just to add, from a pharmacy perspective, we worked really well to gain support from our professional colleagues across all sectors where pharmacy teams operate, within primary care, community, secondary care, mental health, and tertiary care as well. And also, it's not just about the professionally registered staff, it's the whole teams, it's the health champions who support those people who walk into our community pharmacies every day off the high street, and they will be approached and given healthy living advice free of charge around smoking cessation, around alcohol consumption, healthy eating, and improving their physical activity as well. So just wanted to celebrate that, really.
Thank you for those two contributions. Anyone else want to comment on this? Andy?
Just quickly, to almost repeat what I said at the beginning, just to thank colleagues, health colleagues, for the contribution to the work on homelessness. I think this really shows how devolution is building to me, how we're building networks and then everyone's pulling more and more in the same direction. And it's really great to see. I think the pop-up dental service is brilliant, to be honest. And I remember Zahid first coming to me a while ago saying how the health service could contribute more, getting out of some of the restrictions that come with, and I just think the way this is building is fantastic. And from what I've seen, I always say this: giving money is one thing to people, giving proper care, time, and attention to people has more of a change than anything else, to be honest. So I would love to hear more about how that service is developing, but I just would be grateful from today if you could pass back my thanks to everybody who's been involved in developing it.
Thanks again for those comments, Andy.
Just to reinforce what Andy said, it was 370 days when I came to see you first, and I said we want to do something different, and we launched this homeless-friendly program, and that was in the back of the story where someone came and told us that they had to pull their teeth with the pliers because they could not find the dentist. And idea was to encourage people to take it as a part of their normal job rather than just trying to create different services. So all of us, we should be dealing with those homeless people or any other community, whether they have their status, their passport, their IDs, their addresses or not. So we're really delighted that actually 1 year on, we have over 200 practices in GM who signed up to that pledge, and they proudly display in the reception area that you don't need proof of ID and address to sign in, including one of the big hospitals in Greater Manchester. So thank you, Andy, for your support.
Well, thank you, Chair. I mean, just really to thoroughly support this, I look forward to enriching this through the collaborative advisory groups that we're part of. Our assets within the community, there's 2,000 primary care assets, 1,500 of which these groups represent, and I think it's really valuable that we take advantage of these assets to help people who don't access care in other ways. I think quite often there's barriers put up at various care settings. People use community pharmacies, people use dental practices, and people use opticians on the high street to access things that they wouldn't elsewhere. And if we can resource these appropriately to bring those benefits of early detection, prevention, and even providing access to social prescribing, which we don't currently at the moment through those assets, it could be a huge benefit to us in GM. So just really absolutely support this paper, and I think it's really exciting what we can do ongoing.
Okay, thanks for the comments, and obviously thanks to the work that you do. Dharmesh, you want to make any? Sorry.
I was really interested in the eyesight component of what you talked about. I didn't appreciate it was 1 in 5. That's actually taken me aback, and for the reason from obviously the connectivity to some simple things like that at a young age could have a really positive effect on what otherwise could become an emotional mental health problem for them in terms of struggling at school. So I think that connectivity with the work we're doing, it's just simple connectivity like that could really add value.
Yeah, absolutely, and actually, you know, for those of us who work with patients and with eyes, and actually a lot of children who are, you know, actually they're hard to deal with, or actually they are acting up, and actually it's quite often they can't see, or actually why are you not attaining what you should be, and they're getting pressure at home and at school, when actually sometimes it's the simple things, and they just simply don't know better.
Okay, again, thanks for the hard work that you do on this, and again, it just shows the value of working together in Greater Manchester that we can bring these partnerships out of, and so well done, keep it going, and I'm sure we support you. Thank you. Here's an interesting one: winter preparedness. Are we?
Thanks, Chair. Anthony Hassel, Chief Officer at Salford and Trafford CCGs, and also Joint Chair of the Greater Manchester Urgent and Emergency Care Improvement Board, jointly chaired by myself and Andrew Foster, Chief Exec of Wrightington, Wigan and Lee Trust. And I think that sends a really important signal, actually, this year, that what we're trying to do through the Urgent and Emergency Care Improvement Board and through the paper that you have before you today is to really engage a theme of this morning, I think, the whole system in tackling the issues that we face around urgent care. There's an extremely popular TV show whose theme is Winter is Coming. We know, actually, though, winter is already here, and pretty much our systems face so-called winter pressures all year round. And we know that, of course, there is the focus on the 4-hour target measured through hospitals, but it is clear and obvious that the only way to address urgent care pressures is through a system response. So a simple number, in Salford we see roughly 300 patients a day going through our A&E department, but 3,000 patients a day going through our primary care system, and I know much more than that 3,000 number going through other parts of our primary care system, community pharmacists, etc. So it's only by adopting a system approach that we will be able to address this. Thanks to Steve and his team for so ably leading this across Greater Manchester, supporting the system in doing so. And I'll assume the paper is as read, but a few summaries from that. What we've tried to do this year is to align our planning process very clearly to what the system is telling us it needs us to help with. And we have 4 themes: staying well, home first, patient flow, and discharge and recovery. And our whole emphasis has been about creating sufficient capacity in our hospitals, but also taking a system-wide approach across health and care to either reduce the numbers of patients attending hospital or getting people home more quickly. And all localities have developed and reviewed their winter plans in conjunction with the partnership and NHS Improvement targeted around those 4 areas. And all localities are now actively working, for example, to reduce the number of patients who are in hospitals for 7 days or more, and focusing on patients being discharged earlier in the day. We had a very positive GM-wide winter summit last week, very well attended by a large number of senior leaders, where we shared learning and saw some real concrete examples of good practice, and crucially focused on how we can keep patients safe during periods of increased pressure. And we're taking a range of GM-wide actions, including improving access to primary care appointments, developing urgent care services as an alternative to emergency departments, and operating a widely regarded as very positive GM escalation system. So truly operating as a GM system using real-time data, highly important, to align ambulance arrivals to hospital capacity, as well as adopting our own communications campaign. And the hub, the Greater Manchester Urgent Emergency Care Hub, will continue to support local systems across GM. But of course, as John mentioned in his introduction, we are already seeing very significant pressure across our system. And it is therefore important that all localities now catalyse the implementation of their winter plans to enable us to together address these significant challenges. Thanks, Chair.
Thank you. Any comments? Questions? Andy?
Sorry, me again. Just to thank Anthony and all colleagues involved in this work. I visited the hub last year, and it was clear that it made a big difference in terms of managing the pressures, and hopefully we can build on the learning from that this year. I suppose one of my roles at this meeting, Peter, is I can bring connections from what's going on in the wider GM family that may help. And one such discussion is being held by the nighttime economy advisor, Sasha Lord, who has been talking about the safety of our city centre and town centres, 2 cities and our town centres through the winter period and the Christmas period. And NWAS were at a meeting I was at last week where they were saying how much the safe space or the safe haven approach in town centres actually does help reduce A&E admittances. And I just wanted to see if, you know, with a month to go before we get into December and the holiday period, is there a possibility of looking at creating either porter cabin or whatever it might be, you know, in the town centres where we know there will be drink-related admissions to A&E if we do nothing else? Is it worth looking at whether simple provision, which is just sort of camp bed or just glass of water, aspirin, place where people can just have time out, you know, it's simple, but it just needs organising, but it can, and NRAS was saying, it will relieve pressure on A&E if we were to put that kind of provision into our city centre and town centres. It's done in other cities. I don't think we're doing it as much as other places, and I just wondered whether it's worth looking in the month or so before the winter starts and the Christmas period starts. Is it worth looking, you know, at delivering some of that type of provision just to relieve those small number of A&E attendances every night that would otherwise result if we did nothing?
Thank you.
Hello, Cesar. Hi. Yeah, on that point, Andy, I used to work with an organisation in city centre Manchester. You may have heard of Nexus Art Cafe. I don't remember, I think it was on Dale Street or something like that. But they used to run a programme, and they're going back some 7 or 8 years now, where they used to have street angels, which were funded by Greater Manchester Police, who were trained by Greater Manchester Police as well, as volunteers. And those people used to go out and not just help cause, basically stop disturbances in town, but they also used to drag people in who were in danger, at risk to themselves because they were inebriated, and they would then put them in a cab from the 24-hour cafe from which we operated. I don't think that 24-hour cafe is an operation because of funding. I'm not sure if Greater Manchester Police are still funding that project, but I think it was a fantastic campaign which could deliver exactly what you are talking about now.
Chairman, this is, yeah.
I suppose the answer to Anne Jay's point is let's have those conversations with NWAS to see what's the art of the possible, because they're clearly very much around the table with us as part of the system that we've constructed. So let's urgently have those conversations, see what we can do.
So I fully support the idea of Andy, and I know John visited Oldham. We got a great scheme in Oldham Town Centre called Street Angels, some partially funded by Oldham CCG, run by a group of volunteers. They will look after you during the night if you had too much of drink, and if you're a bit confused or all sort of thing, they will provide you sleepers. And we know in Oldham that prevents loads of admission to Oldham Hospital, A&E. Not only that, they also will feed you, and if you're homeless, they will provide you some other support as well. So it's definitely something worth exploring, and it's relatively easy to set it on the local level, on localities level, because we have local intelligence.
Thank you, Chair. I just want to make the point of actually thanking our health and social care staff for the work that they do all year round, but especially at the moment. I work in primary care, and I can see that it's escalating, and that the pressures on our staff, and I think we need to safeguard our staff as well as A&E at the moment is under significant pressure, and the staff deserve our thanks for going above and beyond. The other issue I'd just like to make is that I'm a bit concerned about the configuration of the urgent care treatment centres, about when a patient presents at A&E, are they directed, I'm not talking about the 999 ambulances, but are they directed to the GP urgent care treatment centre, or are they going into A&E? Because that could have a significant impact on actually how many deflections we get from people going into A&E. And I think locally we need to sort of look at that and make sure that they're configured in the right way. I know there are rules and regulations regarding the triage, sort of the way that hospitals triage. We need to get over that and actually put a service in that will have that impact. Thank you.
So, Andrea, great point. I think every hospital which has a 24-hour A&E is now operating a GP streaming service. We've had to balance the development of those services between the fact that we don't want to positively attract people to A&E to access primary care services, because that would be absolutely the wrong thing to do, but with also developing those GP primary care streaming services within those A&E departments so that they absolutely work in tandem with that existing emergency department out-of-hours services, the new extended access hubs that we've got in each neighbourhood. So I think we have seen a quite significant development in those services, but of course there's more to do. You're absolutely right in ensuring that if you don't need to go to A&E because you have a primary care type condition, that you can get access out in your neighbourhood or indeed from your GP practice. So absolutely acknowledge the point.
Okay, well, thanks for the contributions, in particular Andrea, reminding us of the hard work of the staff engaged in this section. We know they're understaffed, That's not our fault, but we can do our best. We do need to be honest, I think, this winter and support each other, and hopefully we can get through better than we did last time. Thanks, Anthony, for your presentation. Healthier Together, Sue?
So I'm doing a double act with Professor Jane Edelston, who's at the back, so we'll do some tennis across the room, I think. So just to find the right thing. We made the Healthier Together decision as commissioners to deliver improved outcomes for high-risk general surgery procedures, because once you're aware that dependent on where you go across Greater Manchester, you have a different outcome. You may be more or less likely to die or have poor outcomes from your surgery. You have to act as a commissioner once you know that there are those variations. And you'll remember that the headline improvement aim was to save 300 lives a year. The changes planned are to meet a series of evidence-based clinical standards, including rapid assessment of people with symptoms, avoiding the need to admit those who do not need hospital care, a skilled consultant surgeon and anaesthetist performing the operation, and very importantly, the right level of post-operative care 24/7 to ensure recovery and rescue if needed. And without the building alterations needed to deliver the full specialist high-risk site capacity, we've still achieved a great deal this year, which I'll pass on to Jane to give you the clinical highlights of. But that has been really focusing on the workforce across hospital sites working together on clinical quality, audit and rotas. Linked to that, having multidisciplinary team meetings to discuss the most high-risk patients, and delivering ambulatory care that is very quick and diagnosis of people that attend hospital with symptoms like abdominal pain to identify whether they need treatment quickly and avoid an unnecessary hospital stay for the majority who don't need surgery. So I'll hand over to Jane to take you through some of the highlights of the outcomes that have improved and what we need to achieve with further implementation for those who do need surgery.
Thank you very much, Sue, and apologies I was a few minutes late, otherwise I would have been sitting next to you. It serves me right, actually. So I'm a consultant in intensive care medicine. I'm the Chief Medical Advisor to the programme, and thank you, Sue, for giving us the background. The paper nicely describes the journey we've been on really for the last 6 years and where we fit into the GM 5-year plan. I think before I go on to the sort of clinical progress that we've made, I think it is worth just a moment just reflecting on why we started the process in the first place. And across Greater Manchester, as Sue said, there's been significant variation in the death rate for patients undergoing high-risk general surgery, and that's both in the emergency setting and also in the elective setting. And if we look at the elective setting for a moment, they're patients who have bowel cancer, those patients by and large, and some of our sites were seeing at 2 years, 40% of those patients unfortunately not being with us, whereas other sites only have lost 20%. And if we compare ourselves with the best in class, which is probably NHS Lothian, it's a fraction of those numbers of patients who have unfortunately lost their lives in that short period of time. Now, for the emergency population, again, we've seen significant variation in not just death rates for patients when we started the programme, but also the need to rescue. And Sue touched on that a moment ago. And the need to rescue is where you've maybe had your bowel surgery, bowels maybe been joined back together, and unfortunately there might be a leak, and subsequently that patient requires to go back to theatre for further surgery. If you've not got the right processes in place, that leak will take longer to detect. And every hour that leak is not detected will have a significant detrimental effect on patients. So maybe if I just give you some of the flavours of the work we've done since we started implementation, which is nearly two years ago. We have made significant progress in all of those acute services, so emergency medicine, acute medicine, general surgery and critical care. We've designed standardised pathways. We've managed to deliver some of those elements of those pathways, as Sue described, by working differently. But we've not been able to deliver all of those pathways. And we've certainly not been able to see some of those benefits that we would absolutely see from having the 24-hour presence. So an example now, the fourth National Emergency Laparotomy Audit report was only published yesterday. That covers the period of December 16 through to November 17. And we probably, within Greater Manchester, have probably saved 35 lives in that period of time from the benefits that we've delivered. And we probably managed to, at that point, we had about 8 out of 10 patients in the daytime having for high-risk surgery, having a consultant surgeon and a consultant anaesthetist in theatre with them. Looking at our current performance, because we monitor it monthly, we're now about 90% in hours, which is excellent progress. But even now, we've only got 8 out of our 10 patients of those high-risk patients get into critical care after surgery. And if we look overnight and if we look at weekends, unfortunately, our performance is not as good. And it's not surprising because, of course, that requires additional workforce investment, and it also requires additional theatre time. And to get to the best in class, which is NHS Lothian, requires a volume effect. So it requires many more patients, because we're only talking of small numbers of patients here. We're probably talking across each of the 4 sectors in Greater Manchester, probably of the order of about 400 patients undergoing this emergency surgery, and probably not that many more undergoing the bowel surgery in a similar time frame. So the numbers of patients affected by this are small, but the benefits are absolutely enormous. We've also managed to deliver some of the supporting services. So Sue touched on ambulatory care. So we have designed 4 standardised pathways for surgical ambulatory care and 5 for medicine. And we have all those pathways delivered now in all sites, not all for the same period of time and not all for a 7-day period, unfortunately. But we have the beginning. We've got huge clinical buy-in. We've also managed to develop pathways which have overcome some of the problems in Manchester for some of the supporting services. So patients who have a large bleed, for instance, from the stomach or the upper gastrointestinal tract, those patients require quite a detailed pathway, which does involve having access to vascular interventional radiology. We've developed that pathway and we're now seeing benefits for patients for those patients. And another thing we've managed to do is to develop innovation. So across Manchester, we've started implementing the concept of surgery school, which you may have even read about actually in the Daily Mail this week. I believe it's actually had an article. And it's certainly a practice that received a Health Foundation grant and has been commended across the UK and is now becoming standardised practice in other parts. But we've now started that for our high-risk elective surgical patients who are having high-risk surgery. And that involves them going for surgery school and, in essence, getting fitter in the short period of time from diagnosis to having surgery. So I think we've made huge progress in the 18 months or so. I think there's an enormous amount still to go at, and our 35 lives are only a fraction of what we could achieve. I can't stress enough, though, to everybody the importance of keeping this implementation period as short as possible. You know, the clinicians are very, very keen now to progress and complete this process. They see the benefits for patients, they see the benefits that are coming from Edinburgh. It's really important that we allow them to now deliver that final phase of implementation.
Thank you, Jane. So we've really tried to underline 2 things. The first is that we've achieved a great deal with excellent hard work by the surgical teams across Greater Manchester, being supported to work together in those single service partnerships in GM. But we can only achieve the full implementation of the planned improvements in experience and, most importantly, lives saved with the capital that was announced nationally for GM over a year ago. The delays and additional steps to release this capital and deliver the capacity for the best high-risk care have not only delayed our actions to reduce mortality and save lives in GM, but have cost a great deal of public money in reproducing and refreshing business cases and the costs to inflation of the capital costs going forward. I know this is being taken up at the highest level nationally, and I suggest we offer John and his team all the support in making our case to finally achieve the planned changes. And that's not just for the people of GM, but it made me smile because I think it's also for people like Mia, who could actually be surgeons in the best place to work in the country.
Okay, thank you, Sue and Jane, for the presentations. Any comments? John? Okay, thanks, Tom, and again, thanks for the work on implementing this and the success that we've had. Let's move on to item 10, workforce race equality. Terry?
It's a pleasure to be here. Cheers for having me. So yeah, I'm the chair of the Workforce Race Equality Steering Group, and we're going to present our paper today, me and John. So a bit of a personal insight into who I am. I run a Educating All program, which is a solutions-based provider for higher education providers to address the barriers faced by underrepresented groups in education. I work with University of Manchester and Manchester Met. The issue for me is access to power and linking the lack of barrier and access for people who are who are not in the decision-making process, but are the stakeholders in that process. So that's my background. I was raised in Moss Side, and the workforce for me is something that's important. My mum was a cleaner in the NHS, and she is now a carer, and I've seen directly the benefits that the public sector has, and the challenges it has in communities like Moss Side, like Salford, like Wythenshawe, and the benefits it can have when it works properly. The public sector affects all facets of life. So it's vital that racial equality is at the heart of that. If we are to say it works, it's operating properly. So you're probably wondering how I became the chair of the Workforce Race Equality. It's not a token gesture, it's a representation of what the workforce is trying to do by linking with the communities it's trying to benefit. And for me, that's vitally important, and John is going to sort of expand on that a bit more.
Thanks, Terry. So yeah, it's not a token gesture. I think it's really important to have a chair who comes from our communities and who can talk directly from experience about what that means. So if we take on board the idea that talent is evenly distributed, so this idea that regardless of your race, regardless of disability, regardless of sexuality, that talent's evenly distributed. And then we think about the fact that across our workforce in the public sector, you're 1.5 to 2 times more likely to get a job at interview if you're white than if you're black. And that you're 1.5 to 2 times more likely to be subject to formal disciplinary proceedings if you're black or from a minority ethnic group than if you're white. And I think clearly we've got something wrong there in our public sector if that's the way that the stats tell us what's going on. So on the 5th of June, we signed up as a collective. So public sector, so that's Fire and Rescue Service, GMP, combined authority, local authorities, the NHS, both commissioners and providers, Transport for Greater Manchester. We all signed up to a commitment to tackle this issue. And you'll see from the paper, we're therefore beginning now to mobilise, because a commitment's great, but we now need action to actually tackle those issues. And there are some really strong reasons why. So I've given you the ethical argument, and there is a legal argument. So if we put them to one side, there's some really powerful arguments about why we should have a diverse workforce, particularly around race. So one is that organisations in the public sector tend to perform better. They tend to deliver better quality services when they have a more representative workforce. They tend to be more financially sustainable. And I think, and that generally, those four pillars tend to be the ones that we talk to, but I want to add a fifth one in because of devolution, and that is the economic case. People from BAME communities are overrepresented in poor areas in our region, and we are the biggest employer in this region, collectively. So the impact we can have on giving people good jobs and providing them with good opportunities evenly, equitably, is massive. So we shouldn't underestimate that. The reason that we chose race and not necessarily disability or other areas is because we've got some really, well, you've just heard them, some profound statistics that back this up. And because we felt that focusing in a particular area would give us more traction and would give us more gains. And we know that if organisations focus in this area, they begin to change the culture of their organisations, and they have a benefit for people from other protected groups. So it's not that it just gets better for people from BAME communities. Actually, the evidence that's coming out is showing us that actually gets better for people from other protected groups. So just a little bit on the structure. So what we've done is we've formed a steering group since the agreement was signed. That steering group has senior members from all sorts of organisations who signed up, from chief and superintendent from the police to a deputy chief exec from the NHS, to our lead for the Equality and Diversity Leads Network, who works at Stockport NHS Trust, through to Brenda Warrington, who's a leader of the council at Tameside. So we've got quite a broad membership. We've got some arm's length bodies supporting us, people like North West Employers and the Leadership Academy in the NHS, who also come along. And we have the National Race Equality Team, who are an NHS body, but they've done quite a lot of work in this area, and they're really, really good advisors. I think there are 5 areas of the plan that we're looking at here, and they're in your paper. So, data. We know that having good data creates change. We know that we've got very different data across our organisations, so we need to do something about that. Culture is really important. I also think narrative is really important. How do we build a narrative? If I go out, I was speaking about this issue to a friend of mine, and a friend of mine is Jewish and white, and hasn't really had anything to do with this kind of work before. And I started to say what I was doing. He said, oh, well, we need to promote the right kind of talent. And that is a narrative that's out there, just when we talk about this. If I was to say we don't have a chief executive of a public sector organisation who's from a BAME background in Greater Manchester, we'd be quite shocked. But then if I said, well, actually, therefore, we need to be representative, some people would say, well, we need to promote the right kind of talent. The narrative we need to get out there is we're not doing that at the moment. We're promoting white people in preference to people from BAME background. That is what we're doing, that's what the stats are telling us. So I think trying to get a narrative out is really important. And we are looking at a narrative that taps into Greater Manchester. So, Peterloo came out, was it last week? We've got a strong tradition. You followed the line from Peterloo through to the Lincoln Memorial, through to disability rights, through to our LGBT community. There's a story we can tell about Greater Manchester being a fair city. a fair city region, and I think that this should tap into that narrative. I think leadership, really important, senior leadership talking about this, engaging with it, that our recruitment, retention and promotion schemes actually take this seriously, and that we share good practice. Some of our partners in the police, in some of our NHS trusts are doing some excellent work, so how do we share that good practice? So I will have one other point, and the only other point is this. So we've gone out for a lead organisation across all of the public sector to lead this work. That advert's gone out this week. I'm getting responses at the moment, and they will be the vehicle to carry through some of this plan. I'll hand back to Terry to sum up.
Cheers, John. So some of the so some of the tangible outcomes, you'll be likely to get a job in Greater Manchester, or interview if you're black, Asian or ethnic minority or white. You'll be likely, just as likely to end up in a disciplinary hearing as a result of performance or capability in Greater Manchester if you're black, Asian or ethnic minority. We'll see a minimum increase of 10% shift in distribution from black people, Asian ethnic minority backgrounds across the pay grades of organisations, so that levels are more representative of the communities they serve. For us, this is an opportunity for Greater Manchester to be the leader of this agenda, not just in the region, but nationally. And we think devolution should be about people, not just infrastructure, and about equality, not just economics. So yeah, we hope this work really thrives and pushes forward. Thank you.
We are very brief because we're running out of time, and I want to give Salford proper chance to put a presentation.
I will be very, very quick. So I fully agree that talent is equally distributed, but opportunities are not equally distributed, and that's where the problem is. So not to offend anyone here in this room, but this is my challenge for my executive colleagues. If you look at the political sector of GM, you will see very fair distribution and representation from all the communities. Can you replicate that in your executive roles across the organization? Very briefly to say, we should not be giving people things in the plate because they belong to a color, race, gender or something. What's our job is to promote opportunities, provide opportunities, and those opportunities come where you start getting people into apprenticeships, you start nurturing them, you start mentoring them, and then you promote them to next level and next level and the next level. And we have some great plans in Oldham to do that, so please do come and visit us.
I'm another one that can't work this. There we go. Conscious of time, I'll keep it dead brief. I just wanted to really thank you for the presentation, both of you. I was particularly struck by your point, Terry, around linking power with race, but also with class and with place where people come from. And this is something that we're thinking about in Manchester, about how we can connect our local communities into access of jobs and using that as a tool to drive through some of the challenges that we've set ourselves on race. The final point is just one around leadership, and I think it's our jobs as all of us in the room today to take this back to our own organisations and localities and not just rely on a steering group to come out with some recommendation in a year's time where we all go, this is very nice. So I think we should all be taking something away from this today, and I certainly am in Manchester.
Fully echo everything that Bev has just said. Congratulate Terry and the passion and the clarity of the presentations. Devolution will have failed, in my view, if it doesn't, in the end, fully, fairly and equally represent all communities in the work and the decisions that it takes. And it's as straightforward as that, to be honest. I just wanted to make a point, Peter, very quickly about the impact of not getting this right. The impact of not getting it right means that you get gaps in services on the ground when decisions are taken, and you don't get services commissioned that serve all communities equally and fairly. It is why an organisation has been created called the Caribbean and African Health Network, a new organisation in Greater Manchester who want to become involved in devolution so that they can convey where these gaps are. Sickle cell is an obvious example, but there are others, particularly mental health services. So I think it's very important that alongside the workforce issues that we've heard about today, we then link that to the gaps in services that we see that come from a lack of representation in commissioning decision making. And I think these two things need to be seen together. But I want to congratulate Terry and say I'm here to support him and the group in whatever work they are doing.
Presentations, can we agree the recommendation with a slight amendment? I think we don't have the power to hold to account, but certainly we should be working with our organisations to ensure it happens. Agreed? Thank you very much. Sorry, Anthony, your colleagues from Salford.
Thanks, Chair. And there's a theme today, hasn't there been, around young people and system working, and hopefully the presentation that Charlotte and I are going to give today will sing to that theme. And just by way of introduction, whilst Charlotte and I will be giving this presentation, this work is work that we have delivered across Salford in partnership with all our different stakeholders and agencies, particularly importantly the children and young people and their families of this great city. So I'll hand over to Charlotte to start the presentation.
Hello, lovely to be with you. So, in Salford, we have been in true co-production style, developing a real vision for children and young people. And this is what we created 3.5 years ago. So we sat down as partners across the city in discussion with young people to say, well, what actually is it we want to achieve for and with young people? And it was this: to enable them all to achieve their potential. And in order for that to happen, these were the things that needed to be in place. They needed to be healthy and safe. They needed to have the right education and be equipped for adult life. They needed to have that voice and influence. And they needed to have aspiration and opportunity. So, Salford the Place, here it is. It's very neatly divided into our 5 health and care neighbourhoods for system organisation. And it's really important to put this slide up because in interpreting the vision that we created to Salford the Place, we then went through a whole big debate about how do we do that. So we have 5 health and care neighbourhoods. We have 4 children's neighbourhoods simply for resourcing purposes, but they interlink. But within that, we also have lots of communities of place which are really important in terms of a differential response if we're ever going to meet people's needs. So we mapped our ambition against this, as in Salford the Place, and did a huge amount of analytical work. We analysed all of the needs of individuals within Salford. We analysed the outcomes that we were currently achieving on the life course from 0 to 25. And then we analysed those by neighbourhood areas, but also by persona types. So we looked at actually where are we working better or differently in different parts of the city according to neighbourhoods, but also according to individuals. What that led to was this. This is affectionately known as the orange segment diagram in Salford, and this is our transformation journey. So from all of that analysis, we then created an approach to working differently in place, an approach to working differently with people, and an approach to working differently around joint commissioning across the council and CCG. We also did a whole load of stuff in relation to social care, but we haven't included that for the purposes of today. So in terms of place, our ambition was to create effective multi-agency early help hubs in our localities. And you can see on the right-hand side how that relates to other system agendas. So the whole approach to public service reform, the whole approach to locality plan delivery, obviously the aspirations of Salford in terms of political and partnership priorities, and making sure that we're using the assets of place in the way that we deliver that. So those 4 multi-agency hubs, we started off with 1. It worked incredibly well. We now have 4, and they're well established. It's important to say that they're totally linked into universal provision in those locality areas, particularly schools, going back to the earlier presentation that we heard. And we've got 4 schools coordinator posts that have the role of actually making that connectivity happen, but it is a whole system responsibility. And every school has a named set of support around it in a kind of a team around the school approach, so health visitors, mental health support, etc. We also developed an early help family engagement strategy which was based on asset-based working. It's a whole family partnership model. It's got an evidence base and we are tracking the progress of that. And in whole system style, it's totally linked into our work on children with special education needs and disabilities, and the response of our responsibilities there in terms of local offer, pathways to support them, and you'll hear a bit about that in a minute. It's also totally linked into our mental health support in the city and a whole support from early need right through to CAMHS intervention. And our greatest achievement, we had Ofsted in only a couple of weeks ago, and their verdict on all of this approach has been, I'll read you these words, early help arrangements are very effective in supporting children and families at the right time, leading to timely intervention that improves children's circumstances. So we're comfortable that this approach, linked in then to the need for more intensive support, is delivering. The second thing we did was look at personas, as I said, and the group, it won't be any surprise to many of you, the group that we homed in on were our hard-to-reach teenagers, those who don't trust professionals, who think that education is probably not having a great deal of point in their lives, and who actually are pretty disengaged. And what we created was something called Fueling Ambitions Creatively Together, which was a hackathon approach working with businesses who came in, did creative work with groups in schools who were hard to reach groups, and who then worked with them over the course of the year, drawing in resources from the university, from our teams, etc., around problem solving. One of those projects currently has the interest of Public Health England as a digital app. It's involved 7 schools, 6 have maintained it, and these are just some headlines around the confidence in terms of the tracking of outcomes. So increased confidence, increased aspiration and motivation, also increased engagement with education, better behaviour, etc. And then obviously we moved on to our integrated approach around commissioning and how we could develop that, and we chose 3 themes, so I'll hand over to Anthony to talk about those.
Thanks, Charlotte. So, as Charlotte's indicated, we chose 3 themes, which I'll very briefly talk about. One around special education needs and disability, one around speech and language and communication, and one around emotional health and well-being related to child and adolescent mental health. And the reason we chose those, primarily because large numbers of families and children were saying that we needed to work in these areas to improve coordination of services and the way services were delivered. But frankly also because of the high cost and high volume often that these services deliver, and the potential for big impact across the city. So with all of these pilots, but particularly the first 2, this was about involving families from the very beginning, inverting the triangle to ensure that we have families at the very top of the way in which we manage their need, and bringing professionals together with families, so for example paediatricians and school staff together to both understand the issues and then put in place solutions. But at the same time, this was about involving the voluntary sector, and you can see reference in there to the Dadley Does It programme, really ensuring that their contribution and their added value was at the very centre of the tests of change and integrated commissioning approach that we adopted. And in relation to child and adolescent mental health services, adopting this circular approach whereby we use digital services to engage with young people to support self-advice, and then following that through with a multi-agency approach to supporting those who are identified as needing support at the next level, particularly focused on delivering that in collaboration with schools. And then, where there was even greater need identified, we really focused on investing in additional services for those in need, and particularly, as well as I say, using a voluntary sector-led approach to support areas such as suicide prevention and working on those at risk of self-harm. Looking forward, of course, part of the challenge here is how we can manage future levels of demand. So identifying those children who are at risk and deploying actions in advance of crisis levels to ensure that we get up the curve in terms of that need. But of course, this is not just about children, and one of the things that we wanted to do as part of our integrated approach was also to start from, if you like, before that birth event, with the development of more proactive and responsive maternity services. And as part of the NHS England Maternity Pioneer Programme, we've been engaging families to develop a much more responsive birth experience through our Maternity Pioneer. We have done that not just in Salford, but across Wigan and Bolton as well, co-developing a model, again, where we empower families, and particularly women, to use personal budgets to enable them to have proper choices around maternity care. And I'm really proud that we have had 5,000 women across our localities acting and using choices through their personal maternity care budgets across the North West, and indeed North West sector, and indeed partnering very proactively with not just staff groups but with our local university to ensure that we're on a loop of continuous improvement. And that links, of course, to our very proud Ingleside freestanding maternity unit, the only one in Greater Manchester, and we see this as a truly Greater Manchester facility, developed in true partnership between the NHS, our provider organisations and our local authority. And if you haven't visited Ingleside, please do so. It is an amazing community hub where we're now developing one-stop facilities to maximise public health outcomes, with large numbers of services co-located together, supporting women and families from that birth event onwards, and with a real ambition to develop that further and faster, with some very significant national interest in what many are seeing as a pioneering model aligned to the Better Births maternity programme. So, in summary, we're doing some really positive visioning, rooted in engagement with children and young families, not just in Salford, but across the North West sector and across Greater Manchester. That has been catalysed by our already well-developed joint commissioning work and our ambition, subject to further discussions, to take that even further by next April. We are seeing impact, as you can see on the slide already, much more to do, but with our collaboration in place with all partners across the city, I'm confident and proud that we can make even further inroads into this really important agenda. Thank you.
Yes. John and Andy may remember an interesting debate we had at the Reform Board about the way forward, in particular two different models about delivering place-based strategies. And I think we discovered we were violently agreeing with each other by the end of it, actually, because what I was anxious about is that we do actually take account of local circumstances, local working relationships, and put them together in a way that might be a bit different in each area, but nevertheless accompanies what both John and Andy, I know, passionately want about working together, about delivering at a place-based thing. And I think there are two crucial components to this. One is, I think, that the CCG and the local authority trust each other and work well together, right, on both a formal and informal basis. And I think the third leg is that having a very successful hospital as well helps to deliver these services. So I think that you've heard the Salford approach. It wouldn't necessarily apply to every area, but I think there's an awful lot of interest to people in the way that we actually actively want to work together. I think it's like any relationship. You have to work at it sometimes. We sometimes have disagreements, but on the whole, we get on quite well together.
Well, to get on with you like that, John, well done. Right, well, as you say, I think people have different approaches, but what matters is what happens at the end. It's not what you do, it's what happens to people at the end, and clearly very impressive outcomes, and so well done to the teams working on this. Moving on, we've got the dates of future meetings. I've got some good news and bad news, I'm afraid, for you here. For those who've been around a long time, and there are a few faces here who've been around a long time, you remember that we used to hold our meetings to coincide with the meetings of the Greater Manchester leaders, which are always on the last Friday of every month. We ceased that practice about a year ago, and we've got a rotator. The consequence of that has been that we've not had many leaders of Kelmers attending this particular meeting, which I think has got a bit of a gap between the thinking that we're doing as a health and care board and what the leaders are understanding. So with the support of the mayor and the leaders were keen, I think, to come back into the fold. So we've raised a system where 4 times a year we will meet on the last Friday of a month, which will coincide with the leaders' meeting again. So we'll get that fuller attendance there. But the other times we can be more flexible and meet when we are. We have a proposal, I don't intend to read about it, so the disadvantage of the system is it's not quite going to be a regular cycle because 4 times a year doesn't fit in. But we'll do that, and hopefully it will mean that we have better dialogue with the leaders. And there are some really big issues coming up, aren't there, which we need to address. So I think that will be really helpful for us. So thanks for that. Okay. Yep. Sorry, the mayor's got one point.
One last comment for colleagues at leave. This week is Living Wage Week, and we were able to celebrate the fact that Greater Manchester Police became accredited this year as a living wage employer. Salford, I think, had already set the lead for Greater Manchester, became the first council. Oldham Council, I understand, voted to start the process of becoming accredited. I just wanted to say, Peter, particularly with our work on the Good Employment Charter for Greater Manchester, and the knowledge that we have that poor or even insecure pay can lead to poor health, it was an appeal really to see if the health service could come to the lead, to the fore on this agenda, particularly as we look towards Living Wage Week next year, to see if we can really start to get much more coordinated take-up across all the GM public sector with regard to the living wage. Realise there are challenges, but they can be negotiated, and if there are costs, maybe they should come from maybe lower increases higher up the pay scale to make sure that we have a flatter distribution of pay across workforces. So I'd just be keen to state the NHS, in my view, should always be the exemplar employer. I think we were having that discussion before in relation to race, and I think in this space, I think it would be good to see the NHS adopting that position.
Okay, thanks for those comments. With that, thank you very much for coming, and thanks for sorting for the host. Okay, see you.